Welcome, welcome. I'm Dr. Yoni Whitten, and this is Ask Me Anything Episode 1. This is a new segment that I'm doing on the Pain Fix Protocol channel where I take your questions about pain, posture, and rehab-related topics, and I answer them in long form so that hopefully the entire community can benefit from the information being shared here. Now, I've selected 4 questions for today's episode, so let's get to it. Question number 1 comes from Shuna. She says, "Dear Dr. Whitten, I have a twisted spine / scoliosis, and although I stand straight and my hips are level on x-ray, my right shoulder is lower than my left, and I often get pain in my back and buttocks, which I ease by lying on tennis balls. Can you recommend any exercise to help straighten my spine, if possible?" She adds, "I'm a 69-year-old female." Well, Shuna, the answer to your question is not so cut and dry. The first thing that needs to be determined anytime you're dealing with a scoliosis is what is the origin of the problem? What's causing that lateral curvature and twisting in the spine that you describe? So there are 2 broad categories of scoliosis. There are structural scoliosis and there are the far more common functional scoliosis. So an example of a structural scoliosis would be an anatomical leg length discrepancy. You're born and for whatever reason, one of the bones in your legs grows longer than the bones on the opposite side. So you can see this sometimes where the people have a history of fracture that occurred in childhood and it disrupted the growth pattern in the bone that was broken. Or you can also see this run in families. I have families in my clinic that come in and everybody has a short leg on the exact same side in that family. The other thing that can cause a structural scoliosis, although it's very uncommon, is something called a hemivertebrae. So when you x-ray the spine and you look at it straight from front to back, the shape of the vertebrae is almost like block shaped like that. Well, with a hemivertebrae, it doesn't grow properly and you end up with a wedge shaped vertebrae like that. But like I said, super uncommon. There was a 2005 study done in Israel that looked at over 78,000 babies born in a hospital, and they found that the incidence of hemivertebrae in that population was 0.0003%. So super uncommon. A couple other things that can lead to this are spina bifida and cerebral palsy, although if you had those things, you would likely know about it. Now, the far more common variety of scoliosis is what's called a functional scoliosis. Now, this very often stems from musculoskeletal / neurological problems, and when people come into my clinic with those types of problems, I tend to look at what I call the foundations of the body. So I check the feet and the structure of the feet and compare one side to the other. I then move up to the pelvis and I use a 3-dimensional model for assessing the pelvis. So I want to look at it from top to bottom. You mentioned that your pelvis was level, which is a top to bottom assessment, but I'm not sure that you took into account the second aspect, which is front to back. So the pelvis can actually rotate at the sacroiliac joints, and a twisting of the pelvis will necessarily lead to a twisting of the spine because the pelvis is the foundation that the spine sits on top of. And then finally, and most importantly, I will look at the head and where it contacts the neck, and then I will check the shape and structure of the neck and the muscularity on both sides, comparing right to left. Now, problems in the head and neck will manifest down the kinetic chain because where the head leads, the body follows. So if you're confused about where your scoliosis is coming from, my strong recommendation would be to have it professionally assessed. Make sure that there is no anatomical leg length discrepancy, and the gold standard for checking that is what's called a leg length study. It is an x-ray that is not commonly done, and they will x-ray you in a standing position with a ruler actually on what's used to be called the bucky. So the ruler is actually built into the x-ray, and that'll allow the radiologist to measure bony landmark to bony landmark from left to right and make sure that the bones are actually of equal length or close enough that it's not the cause of your problem. There's also a jungle test where you wouldn't have to submit yourself to the radiation, where somebody can kind of eyeball it and say, you're close enough that I don't need the x-ray. But you're gonna need a professional assessment, and then see somebody who can assess head and neck position and 3-dimensional positioning of your pelvis, as well as the structure of your feet. Only when you have the answer to those questions can you make specific recommendations about exercise exercises to help you. But the good news is, if you fit into that functional category of scoliosis, which is far more common, yes, there are exercises that can help you, but you're gonna need that assessment to figure out which one is gonna work best for you. Question number 2 comes from Linda. She says, "Hi, my question is, I'm not able to bring either knee more than halfway to my chest. I've been active doing many different things for years, such as yoga, walking, qigong, and rebounding. I've tried different exercises to help correct this, but nothing has worked so far. I hope you can help me." Well, Linda, if you came into my clinic complaining of a problem like this, the first thing that I would do would be to assess the mobility in both of your knees. And specifically what I'd be looking for is what happens at the end range of motion. When I bend that knee as far as it'll go, what happens? Because one of two things is going to occur at that very end range. It'll either be a hard stop or it'll be a soft stop. Now, what I'm calling a hard stop means that when you get to the end range, it's like hitting a wall, and that joint won't move another millimeter. Oftentimes, there'll be pain associated with it if you try to go further. Now, some things that can cause a hard stop are severe degeneration of the joint or a bone spur, where pain-sensitive tissues inside of that joint that should never contact one another are actually touching. And when that occurs, the body will initiate something called a splinting response, where it'll tighten up all the tissue around the joint as a way of protecting you. Another thing that could cause a situation where you're having a hard stop is after trauma, where ligaments or meniscus inside of that joint capsule have been damaged and they've either bled out or swelling is present and it's filled up that joint capsule, and there just is no longer room for the joint to fully bend, because when you try to, it squeezes all that fluid up against the joint capsule from the inside. Think of like a water balloon that has too much water in it, just like about to separate when you move it or try and bend it. And then finally, I would consider congenitally tight ligaments. So we've all seen those contortionists on television that can move their joints through these really extreme ranges of motion and twist their bodies into crazy positions. Well, there are a group of people who exist on the opposite end of the spectrum, and I've seen just a couple of these in 16 years of clinical practice, where they're born and their ligaments are just super tight, and so is their connective tissue, and so they can't move their joints through a full range of motion. Now, when this is present, number one, it's present from birth, so you would have never had the ability to move your knees through their full range of motion. Number two, it's usually present in multiple joints in the body, so it's not just the knees. A person with a knee issue might also have, say, something like elbow restriction, where they can't fully bend their elbows or fully straighten the elbows. So if that's the case with you, then you might just be one of those people with congenitally short ligaments. But if you fall into that second category, and we say like it's a soft stop where you get to the end range and there's still a little wiggle room in there, well, then it might just be a situation where there's a musculoskeletal imbalance, or you may have not moved that joint through its range of motion for so long that you've had adhesions, which are little bits of scar tissue build up in the connective tissue around it, that's now restricting the range of motion. Now, if you have that soft end feel and it doesn't hurt when you wiggle it at that end range, then you might fall into that category. If that's the case, then immediately what I would get you to do would be to go into a non-weight bearing position. So a lot of the activities that you mentioned, yoga, walking, qigong, and rebounding, are weight bearing. In the case of rebounding, you're bearing a lot of weight and there's a lot of compressive force on that knee. So I want to remove all of that, get you lying on your back, and try and move that knee through a range of motion. Now, if that feels better for you and the range of motion increases, then you might try something like knee rolls, where you put your feet up on top of an exercise ball and you rhythmically just roll that ball back and forth close to your body and moving it away, and see what it feels like to increase synovial fluid and try and work that knee through a range of motion when there's no weight on it. If you start having success there, then you could branch out into self-myofascial release techniques, where you assess the muscular tissue that crosses the knee joint on the front, back, and sides of the thigh, and start working your way through any restrictions in that connective tissue, breaking up any adhesions that may have formed along the way. Finally, you might move into some contract relax techniques where you are working that muscle that crosses the knee joint through an isometric contraction and then periodically trying to work deeper and deeper into lengthening those muscles. And it's very helpful to work with a professional for something like that to make sure that you don't push yourself too far. But step number one, figure out if you're a hard stop or a soft stop, and then figure out what's leading to whatever type of stoppage you have. Question number 3 comes from Nick. He says, "Hi, I love your videos and I'm using a lot of your techniques in my everyday life. I saw where you did the video on tennis elbow. I, however, tend to get pain in the ulnar tendon." So Nick's elbow pain is here on the inside portion of the elbow. It tends to be worse on the harder lifting days. I'm assuming that you mean by that, Nick, that when you lift heavy weights, the pain increases. Doing the prayer and reverse prayer stretches and the push-outs that you mentioned in one video help, but it's still there. It can wake me up in the early morning. I'm hoping you may have more methods to get the pain under better control. Thank you. I will continue to watch your videos and I love what you're doing. Thank you, Nick. So the injury that you're describing, or the pain condition that you're describing, would probably be diagnosed as a medial epicondylitis or a golfer's elbow. Now, you say something else here that is critically important to understand when trying to resolve these issues, which is that the pain increases as a result of an activity that you're engaging in. I'm guessing that you're engaging in it on a regular basis. So the thing to understand about this injury is that although it is often described as an epicondylitis, we are more and more diagnosing these problems as a tendinosis type problem. And the difference between the itis and the osis is important. So a tendinitis implies the inflammatory nature and often the overuse that goes with these types of problems. But the tendinosis points to what's actually occurring when you look at the tissue underneath a microscope, and you can see that there's actually micro trauma. There's little tears in the tendon itself that's actually creating the inflammation and the pain that you're experiencing. So when that pain condition is getting worse as a result of an activity that you're engaging in, and if your primary goal is to get rid of the pain, then you need to stop or modify the activities that you're doing that are creating that problem, because it's quite possible that you're taking these little micro tears in the tendon and you are actually tearing that tissue even more when you're engaging in that activity. So you've got a few options here. You can change the movements that you're using at the gym. You can alter your range of motion, and say if you were doing like a barbell row underhanded, going to an overhanded row would completely change what's happening at that tendon, and it might even eliminate the pain. So playing with different angles can have a big effect on this. The other thing that I would strongly recommend, if you're not doing it already, is get yourself a quality set of wrist wraps. These are heavy-duty nylon that go around the wrist, and there's a little tail that comes off of it that allows you to wrap that around the bar, and hopefully you're nodding your head because you're already using these. But what those would allow you to do is on any exercises that require you to grip very heavily, you can offload the tension from your gripping muscles onto the strap, and that allows you to grip very lightly. So when I've dealt with this problem in the past, I've switched to using straps, and that offloads the tissue on the inside of the elbow tremendously and can give you the break that you need to allow that tissue to recover. Modifying exercises, like I said, you may actually have to cut certain exercises out for a period of time and allow that tissue to heal. Now, beyond that, you're dealing with a tissue, a tendon, that has an extremely poor blood supply. And so primary treatment goal when working on this situation, besides stopping the insult, is to bring blood to an area that has very poor blood supply. Now, cupping can be very effective for this. You can also use self-massage, percussion, myofascial release, Graston, active release technique if you want to see professional about it. But your goal is to bring fresh blood into the area so that you can flush out the metabolic wastes that are associated with the damage that's been done, and so that you can bring in a fresh supply of nutrients that will be necessary to repair the damage that's been done to that tissue. Another thing that's super helpful for these conditions is red light therapy. If you want to step up your game a significant amount, red light therapy is awesome for killing pain, accelerating cellular metabolism, so it'll actually speed up that repair process. So I often describe it to my patients like if you were building a house and you had one crew working on that house, so they're working 8 hours a day, it'll take a certain length of time for that house to get built. But if you bring in 2 more crews, and those 2 crews also work 8 hours a day, now you're working 24 hours around the clock, and that house gets done much, much faster. Well, that's how red light therapy can work on that tissue. And then if you don't want to spend that much money, but you still want to invest in your recovery process, rock tape is an absolute must for these types of injuries. I've used it extensively both on myself and with patients in the clinic. It works 24 hours a day as long as it's applied. So I would put on application on the inside of that elbow and leave it on for 3 or 4 days at a time. Just make sure that you are applying it correctly, because that's the key to getting the maximum benefit from your tape. But that would be a full-blown strategy for repairing the injury that you're dealing with. And then long-term, for preventing it in the future, you will very likely need to spend some time focusing on the opposing muscle group here, which would be the wrist extensors. And I've got videos that talk all about strengthening that muscle group, but you need to bring those 2 groups back into balance to prevent that problem from coming back again and again and again, especially as you get stronger throughout your body. You need to make sure that this often neglected muscle group is brought into the balance with the rest of your body. The 4th and final question comes from April. She says, I have chronic pain and tension in my neck and upper back from parentheses, I assume a lifetime of poor posture. Should I avoid exercises that target the upper trapezius, or would that actually be beneficial? Thanks. Such a good question, April. I love how you're thinking about this problem. You're thinking to yourself, what can I strengthen to improve my situation? And that's a really good starting point. But we do not want to be targeting the upper trapezius with strengthening exercises when there's postural dysfunction present. And here's why. One of the first manifestations that we see with postural dysfunction is a forward head position. That's where the head shifts out in front of the gravity line. Now, for each inch that it shifts forward in front of that gravity line, it's gaining 10 pounds of functional weight. And the muscles that attach to the head have to work that much harder to hold the head when it's in that forward head position. So the analogy here is holding a dumbbell. Imagine me holding a 10-pound dumbbell this close to my body. And then imagine what it feels like to hold that exact same weight out in front of my body like this. Way heavier in this position, right? My bicep has to work way harder. Well, the traps have to do the exact same thing with anybody who's got a forward head position. They're just working like crazy, the same way that bicep is, to hold all that extra weight. And they're having to do it all hours of the day that you're not lying down, right? When you lie down, those muscles finally get to relax and offload that intense contraction that they're in all day. So the last thing in the world that you want to do is add load to a muscle like that that's already working 16 plus hours a day. Instead, what you would want to do is strengthen the muscles of the posterior chain. That's all the muscles on the back half of my body. If I was to cut my body into front and back halves, it would be all the muscles on the back side, and target those muscles that are going to help pull me into an upright posture. Those muscles can actually offload the traps. So if I was to strengthen, say, my scapular retractors, the muscles that are responsible for pulling my shoulder blades back and opening my chest, that would allow me to offload those traps. So that would be like a horizontal rowing exercise, or a seated row, or a chin up where I'm going through a full range of motion and then really squeezing in that top position and trying to open the chest. Those would all be very beneficial for helping to offload those overworked muscles at the top of your neck, the upper trapezius. The other thing that we can use here is a really interesting technique called reciprocal inhibition. And this is where opposing muscles are actually neurologically wired to work in a push-pull scenario. So the classic example here would be bicep-tricep. When my bicep contracts, It neurologically forces a relaxation of the tricep. Same thing happens down in the legs. When the muscles on the front of the leg contract, it neurologically relaxes the muscles on the back side of the leg. And this is what allows us to cross crawl or engage in walking when we're functional adults. Now, when you're talking about the upper traps, you're talking about a muscle that pulls the shoulder blades up. And so working the lower trapezius muscles and the muscles that are responsible for pulling the shoulders down can actually cause that same type of reciprocal relaxation in the upper trapezius muscles. But again, you're talking about muscles responsible for pulling the shoulder blades back and down, and those are the types of exercises that you should really be focusing on. Another way of targeting this would be to restore normal head position. So take the dumbbell out of that position, get it back to here, and you will offload that tissue. Same thing with the head. Get the head back into a normal position, and you will offload that tissue at the base of your neck and in your upper back. Active traction is the way that I would go for this. I'm going to put a link to a video that I did where I talk all about that in the description down below. And that is all for Ask Me Anything episode number 1. If you guys enjoyed this, make sure to give the video a thumbs up and subscribe to the channel so that you're updated every time a new episode comes out. And if you want to get your questions answered, send them over to support@painfixprotocol.com. Make sure to use the email subject line Q&A. If you don't use that subject line, there's a chance I might not see your emails. So send those emails over, and maybe your question will be selected for the next episode of Ask Me Anything.